We're going to have a question and answer. If I could just have the presenters come up. And while you're making your way up, we will take questions. I just have a question for, and I would like you guys to go down the line and discuss how you do your sleeve, because I know that Greg you saw some of it in his slides, how he has evolved his technique. But if you can just kind of let us know, and Kevin, you can start.
Well, mine is fairly straightforward. I use a 32 French bougie. I start about 6 centimeters proximal to the pylorus. I use a 4.8 millimeter staple load, the green load, most commonly with the two major carriers. I use staple line reinforcement on both sides all the way up, and I try to preserve that angle of hiss that Greg was mentioning carefully. And I tend to, I'm close to the bougie, but I wouldn't say I could probably go a little closer. I have a small margin of error off the bougie when I do it.
Greg?
So 32 French, slightly loose. I take most of the antrum, so I'm within 2 centimeters of the pylorus. I leave a centimeter to maybe 1.5 centimeters at the cardia, and then I suture invert that. I suture invert the distal staple line, and I suspend the omentum to the staple line. I started doing that about 200 patients ago, because I started seeing people come in 3, 4, 5 years later with all kinds of strange gastric coilings and other things that happen. So I think that's the last sort of convergence of technique that I talked about, is to kind of anchor that stomach with the omentum.
The group sleeve is 32 French bougie, as close as possible from the pylorus. First you're firing green cartridge, then gold or blue, and we drain all the sleeves.
34 French bougie. If it's first time, no revisional, antrum green, and then blues, and I oversaw the whole staple line. If it's revisional, all green, and all with buttressing material.
32 bougie. Green cartridges for the first 2 firing from the antrum up. Oversaw the whole suture with seroserosal apposition, and we always do an epiproplasty at the top of the sleeve.
I use a 38 French bougie and try and preserve as much of the antrum as possible. Individualize staple loads and oversew it completely. Leave the posterior gastric adhesions to prevent twisting.
Mm-hmm.
I like the posterior gastric adhesions to prevent twisting. I use 38, oversaw the staple line, green, 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 blue all the way up, don't buttress, and put a drain at the end.
34 French, green, green, all blues, peri-strip staple line reinforcement.
Okay, can we'll take a...
Thank you.
Is it Samer?
Samer Matar, yes. So along the same vein, I'd like to ask the panelists about their use of drains, routine versus selective. I know that Raul appears to be a very big proponent of using drains. However, we heard today how, for example, negative intrathoracic pressure can either promote or propagate a leak. And so I wondered if drains that are placed routinely, do you worry that they might propagate or promote a leak? And if you do use drains, do you place them on bulb suction, or do you just leave them to drain by gravity?
I put a drain in my sleeves, but I still drain my bypasses too. I'm old school that way. I look at it, I tell my people that it's quantitative. I mean, it's qualitative, not quantitative. But I think that certainly in general surgery, the data is that, you know, you putting in a drain is not going to cause a leak. But I'll let, actually, Raul, why don't you start that off?
Yeah, I agree with Marina. I also drain all my primary bypasses, primary sleeves, all reoperative surgeries. I use Blake drains. And we are close to 470 something 570 something sleeves, close to 600 probably. We had one leak at the very beginning. We didn't have leaks after that. So I'm not sure if it's the oversawing, if it's a staple, if it's the bougie, or if it's a drain. But as long as it goes good, I'm not going to change it.
Anyone else? Draining, not draining?
Well, I have never drained a sleeve in over 1,000, but I used to drain the gastric bypass.
I still drain the bypasses. I don't drain the sleeve, and I'm a simple man. Every leak I see from the bypass is in the first 7 days. Even that Raul presented that some of the anastomosis ended up being like 9 days. So I set the patient with the bypass with the drain home, and we remove it when they come back at a week. But if I want to have the drain for the leaks I've seen with the sleeve, I need to leave the drain for a month or so, because most of the leak that I've seen are after 20 days. Maybe because they don't have a leak, so that's the argument I have with Raul sometimes. But I don't leave a drain because most of the leaks I've seen are late leaks in the sleeve, so I don't find a reason to leave a drain.
Greg, you drain?
I quit doing a leak test in the operating room a long time ago, and I've never drained for that reason. That you come back, you have a leak, and then there's a CT scan with the drain plugged up next to the big abscess. So I just tell the patients to call immediately if you're still using, if you have to start reusing your narcotic for pain, sudden pain, fevers, and the leaks can happen in the first month. So
The front, Mike.
My question is about intraoperative endoscopy. It's interesting that most of you, if not all of you, are also experts in doing endoscopy, and you advocated doing preoperative screening and endoscopy. However, you didn't talk about doing it in the operating room. And I would argue that doing a sleeve gastrectomy and using a bougie, you're creating extra steps. And if you use a standard gastroscope, which is 29 or 30 French, and you don't, and you're not hugged up against it, you're still going to get, what you're trying to achieve without the dangers of a bougie, as well as being able to do an intraoperative leak test, which in the gastric bypass literature has demonstrated several years ago to be helpful. So I'd like your thoughts on that.
You see, the problem is, I'm sure it happens to some of the surgeons here. Stapling a bougie is bad. Stapling a scope will be very bad. It will be very expensive. So we use the scope, not routinely. We use the scope sometimes, but to calibrate with the scope, the risk of, stapling the scope, twisting the scope, you need a very good endoscopy. If you're doing it by yourself, I will agree with you. But if not, I wouldn't use the scope.
I mean, you're not using the actual scope. I mean, you're using it as a bougie, but your light is on, you're going in and out. You're using it to assure yourself that you're not compromising the integrity of the alimentary tract.
I'm sure Manuel will tell you, Manuel is an endoscopist, so probably he has a better answer, but he will tell you that some of the kinks you see and some of the strictures you see, the scope goes very easily, so the scope is not guaranteed that nothing is going to happen. I don't know, Manuel, if you want.
I prefer you guys to have a bougie inside instead of endoscopy intraoperative for many, many reasons. The one that you can damage, that's hurt my pocket, and the other is that you have zero orientation by doing your scope. So what is going to orientate you is the laparoscope. So by doing that, you can position a bougie. And just tell you guys, if you let your endoscopy alone, doing the endoscopy, and not saying what they are, they will perforate it, because we lost every single notion of anatomy. Who gives anatomy for us is the light of the laparoscope. So I don't find any use besides reoperations with using endoscopy.
I think that anything you do to make your surgery safer is welcome, and there is nobody that can argue with you in putting a scope versus putting a bougie. But if you believe that the scope by itself is going to prevent you from having strictures, that's a mistake, because there are things that happen while you do a sleeve. It's a simple but not an easy operation that might create a stricture with or without the scope, with or without the bougie. And that is something that we've learned from Dr. Dai's video, that he shows it so nicely. And what we mentioned all along is the traction that you're using, trying not to put too much traction with a scope in. You can create a stricture, a narrowing. So I think that scope or bougie is the same, whatever you feel more comfortable, provided you don't violate many other tenets. Traction, corkscrew, too close to the incisura angularis. Those are the things that I would pay attention to.
We're going to go to the back, Mike, but I do want to say you clearly have an excellent assistant, because I would never be able to watch somebody else do the scope, pull it back, because people don't usually follow along very well with the operation.
Hi, Stephen Bowers from Mayo Clinic, Jacksonville. My question pertains to the decision to do operative or non-operative management of a leak. And that I've seen two patients who had initial non-operative management of a leak after sleeve who presented with a delayed perforation 2 and 3 years out, eating, of all things, chips and salsa. And I know that, Raul, you've documented that a large number of gastric fistulas develop after non-operatively managed leak. And I don't know if anyone else has seen that, or what is your decision process on whether to operatively or non-operatively manage a leak? Thank you.
Thank you, Steve, for your question. I think that you cannot 100% guarantee that by doing an operation in this patient population, you are not going to have a fistula. In the gastric bypass, we don't see that many leaks, but we see fistulas, and they're exactly in the same position where we see the leaks from the sleeves. They're very proximal, close to the G junction. That's where you're going to see probably 80% of your gastric fistulas. And I think that is because the stomach is going to stick to the area of the leak and create the fistula. So you might be lucky and you have a fistula. You might be unlucky and you're going to have a patient which is unstable, becomes septic, and that's the one you need to operate and drain. But I think that basically the algorithm is patient is hemodynamically unstable, is getting septic, you have to operate, you have to drain, you have to put a jejunostomy and get the hell out there. Patient is stable, you can watch, observe, and those are the ones who are going to possibly develop a gastric fistula.
If I could make a comment on that, I think that when you decide to make your approach, it needs to be based on the fundamental principle of why these patients have a leak. And the reason we see the leaks in the way we see these leaks is they have a relative distal obstruction with higher pressure proximally. So any intervention that you have should be based on immediate control of sepsis, but ultimately to close this, you need to relieve that pressure distally. That's the difference between a gastric bypass and a sleeve gastrectomy, I think. And so whether you put a tube by it or a stent by it or any other intervention, however you approach it needs to be focused on relieving distal pressure, otherwise it will not close.
But Saeed, having said that, have you been doing like a suromyotomy on your incisura or anything, or a pyloromyotomy if you've had, maybe you haven't had to go back for a leak, but if you had? Because I mean, I think a lot of the distal obstruction data is more recent. We now know that that's really the cause and the underlying reason that these leaks last 3 months or longer. And so in the beginning, we went back for a leak because the patient was unstable. You closed it, it still leaked.
I think that seromyotomies don't address the problem and potentially are a dangerous intervention. I think there are a lot of complications you have. And my approach for these difficult leaks, and that's one nice thing, is I've had lots of these complications myself, and so plenty of opportunity to experiment with different ways to fix it. But simply put, the easiest way and safest way to fix these patients is to put a tube through the skin, through the leak, past the distal part of the stomach, in past the pylorus. You can feed them, you can drain them, they don't need a nasogastric tube, and it invariably gets better. We've done several like this from our own and other people's, and it's a very effective way to do that. You need endoscopy to do it, interventional radiology to do it, but it's very easy to do.
I would say, Marina, that we're talking high leaks, I assume, because, I mean, the distal leaks are a little bit different. So,
right.
So for high leaks, the pressure, the high pressure system is very important. So there are many ways to do that. What Sajid does is very interesting, because we like to put sometimes a big NG tube just to maintain the pylorus open. That will decrease the pressure. He's doing something even better. He's going to do a gastrostomy or whatever, a tubostomy through the leak. That I think is very interesting. But we've been doing pyloric dilations. Some people are doing Botox in the pylorus. Whatever you do to decrease the pressure of the system early is valid, because that leak, as long as the system is a high pressure, that will stay, and that will stay for a long time.
We're going to take the back mic on this side.
Yeah, thank you. May I ask the panel, if you have to repair the hiatus with a mesh, what kind of mesh are you going to use, and what's the rationale of using it? Thank you.
David, you want to?
I use absorbable synthetic. Basically, I don't want to have something that's going to potentially erode into the esophagus. Same reason I don't use a permanent prosthetic for periesophageal hernia repair.
Exactly the same. Agree completely.
So when you say but it's a bioabsorbable versus a biologic, that's what you're using?
Correct. It's not porcine, not bovine, and not human derived. It's synthetic but absorbable over 8 months.
I use a crural patch, which is a non-absorbable, no biologic mesh. And the way I place the patch is on the distal aspect of the crust, really down to the V, to the corner of the V, staying away from the esophagus. I think the key is not to put it near the esophagus or circular to the esophagus, but you stay in the lower part, which is the area where you want to reinforce the most. I believe I have in hundreds of paraesophageals one erosion.
We're going to take one more. We'll take the front mic, and then we're going to break, and then come back. But go ahead.
I would ask you, Dr. Zarar, ask the panelists, now we talk about intraoperative leak test. At least intraoperative leak test can prevent the early leak, not the late leaks. What's the panel think about it?
Greg, you want to start that off? I think you said you stopped doing a leak test, or?
Yeah, I never had a positive leak test in the operating room with this operation. I always do a leak test with the gastric bypass and a duodenal switch because I have a hand-sewn anastomosis. I think that's a different situation, but a long linear staple line like this, you could have a negative leak test for hundreds and hundreds of cases and yet still have a leak rate of 2 or 3%. In fact, if you ask people, have they ever had a positive leak test in the operating room on a sleeve gastrectomy staple line, you might get a no from most of them. It's very rare.
Okay, thank you. I think we're going to take a 15-minute break and then come back.